Here we have a supine patient. We tell the patient to turn the head towards one side and we expose all the anterior lateral neck. From the mastoid process, that is what I'm showing you at the moment, we find that the beginning of the scum muscle, which is sternocleidomastoid muscle. With the finger, with the index, I'm following all the muscle. This is the sternal part of the scum. That is the part that goes all the way down to the sternum. During a contraction, the muscle comes out and we can see that the tendon goes all the way down to the sternum. I ask the patient to lift the head a little bit. It is a light movement is enough to show it. Let's now see the treatment of the scum muscle as well as the scalene muscles. The patient is supine. Now we ask the patient to make a flexion, a very gentle flexion to locate the scum. As we saw before, the palpatory anatomy is quite visible. Then we use a pinch grip, and with the pinch grip we grab the scum. It has to be comfortable, it doesn't need to be painful, even if this technique is always a little bit annoying and unpleasant. When with the pinch grip we have palpated the neck in order to find the trigger points and then the throat band. We will do the pinch grip to do this ischemic compression. Of course, we would have no possibility to push against anything hard. That's why we need to do this ischemic compression with the pinch grip. It is a quite long muscle, so we can decide where to work and where to palpate depending on where the throat band is. This ischemic compression can be held for several seconds, can be 30, 60, 90 seconds maximum. A reduction of the symptoms gives us a positive feedback of releasing a trigger point.
Next, we locate the scapular spine by following the medial margin and going upward. We observe a depression here. This is the scapular spine extending to the area near the acromioclavicular joint. Note that the trapezius muscle is mainly innervated by the accessory nerve, the 11th cranial nerve. Next, we will examine the movements in relation to the fibers. The elevation movement is provided by the upper fibers of the trapezius, the adduction movement of the scapulae provided by the middle fibers of the trapezius, and the lower fibers are responsible for scapular depression, as you can see. Now we will search for the trigger points of the upper fibers of the trapezius muscle. Our search should focus on finding the taut band, which indicates an abnormal state of tension in the muscle fiber. Practically at the top of the trapezius, we follow the muscle's path, and once we palpate the taut band, we can enhance our search by putting the trapezius under tension, slightly tilting the head, keeping in mind that the trapezius originates from the occipital area. Once we find the taut band, three situations may arise. Local pain may be present, or pain may radiate from the same point either upwards or downwards, and small fasciculations might appear visibly while staying in the same spot. After identifying the trigger point, we apply digital pressure to create a situation of low blood flow, or rather hypovascularization, which creates a relative ischemia. We keep the pressure for about a minute and a half, or until we feel the taut band release under our thumb. At this stage, the pain perceived by the patient decreases, and if there is any eventual fasciculation, it tends to disappear as well. The technique we just reviewed is a point pressure that helps us easily locate the taut band. The trapezius muscle is one that anatomically allows us to use a different grip as well, which is the pinching grip enabling us to find and treat other trigger points also in the middle fibers, as we are doing now, carrying out nearly the same technique we just explained, but employing this different grip. Now we will execute the technique on the lower trapezius fibers. How do we engage the lower fibers? We request the patient to pull back both the shoulder and elbow so that a contraction is created that makes the entire margin of the trapezius stand out, as you can see, and thus also the lower part. At this point, we pinch the muscle in the lower branch and ask the patient to release the contraction to grasp the lower fibers of the trapezius this way, in this manner. Our objective is always to locate the taut band and discover, as we have seen before, the area of local or referred pain according to the patient, or we can find fasciculations as we have noted. At this stage, we perform the technique as we have seen before, maintaining this compression for approximately 90 seconds to deactivate the trigger point of the lower trapezius fibers. This will act on the pain perceived by the patient, which tends to decrease. And if any fasciculation happens, as we've said, it tends to go away as well. We can apply another technique. The one we just used is one, and this is another that involves accessing the deep fibers like this, which lets us find and address other trigger points as well.
Now I'm placing my hands on the so-called QL. So it's the K12 area, the last rib, where we have the QL, and we find its upper margin. We know that the QL enters the first four lumbar vertebrae and the iliac crest, so in that area it will be easy to locate and palpate trigger points. Once we find the taut band and the trigger point, I will make the ischemic compression. Of course, I will do the ischemic compression for the time needed to release the contracture. Let's now see the same technique on the QL and let's try to stretch it. Let's do just a little variation. Let's stretch it. Let's cross the legs. The iliac crest goes down, it gets farther away from the 12th rib, and then our QL will be stretched. In this position, we lean on top of the patient and we do this ischemic compression. It's a very sensitive spot, so we need to be cautious and pay attention to the reaction of the patient. When it's better to use this position or the other one. So the one with the crossed leg is better, and we use it when we are dealing with patients who are very contracted and it seems like the iliac crest is right on top of the 12th rib. So it's almost impossible to touch it. So in this case, we prefer to cross the leg and stretch the QL because otherwise it would be untouchable. This is just a hot tip.
True sciatica is often confused with that generated by trigger points. Obviously, in cases of sciatica generated by trigger points in the gluteus medius, minimus, and piriformis, the symptoms of neuropathy are not present. Therefore, if the sciatica is due to trigger points, we do not have reflex alterations, for example, nor loss of strength, nor changes in feeling. We only have the typical pain radiation, which can be easily identified through trigger points. To locate these muscles, we first identify the iliac crest. We know this is the patient's iliac crest, and we also know that the gluteus medius originates from the iliac crest and inserts into the greater trochanter, while the gluteus minimus originates slightly lower than the gluteus medius, a bit deeper in the posterior iliac fossa. It inserts into the greater trochanter as well. Once we have identified the area between the iliac crest and the greater trochanter, we can establish our action zone. In this zone, we will have the gluteus medius and minimus. At this point, once the area is found, we can ask the patient to perform hip abduction, meaning to lift the leg. While resisting with one hand, we can palpate the contraction of the gluteus medius and minimus. because both of these muscles are abductors. At this stage, we ensure the patient is comfortable and use both fingers to locate the tense parts of these muscles. Once we find the tight area, which may correspond to the pain referred by the patient right at the moment of our palpation, we locate the tightest part that corresponds to the trigger point. Once we find the trigger point, as in this case, we ask the patient, is there radiation going down the leg? If the radiation is typical of the sciatica described by the patient, we can be fairly certain we have identified a trigger point for sciatica. We can choose to apply pressure on the trigger point in various ways, using our thumbs or fingers, and we maintain it for about 90 seconds or until we feel the muscle give under our fingers. After reducing the tension of the trigger point we found, we look for others, always in the gluteus medius and minimus group. The important thing is to stay in this area. If we want to actively locate the piriformis with the patient's muscle contraction, we flex the patient's knee and request that they move their heel inward. Now, with this rotation, since the piriformis rotates externally with the hip extended, the piriformis will contract, and in this case, we'll feel the piriformis muscle fibers contracting under our hand. Now that the piriformis is engaged, feeling it well with the patient's muscle contraction, let's locate the trigger points. The most represented trigger points of the piriformis muscle are located at the origin and insertion, meaning in the sacrum and on the greater trochanter. How can we be even more precise? At this point, we have the patient perform another contraction, asking them to push their heel inward yet again, so we can better feel the muscle contraction beneath our hands. At this point, asking the patient for those contractions while we resist their inward heel push, we move our hand in contact with the piriformis along its path, where we feel the tightest part. That is, where we sense the greatest resistance beneath our hand. We get into a more comfortable position and concentrate all our force on that point, even applying double pressure with both thumbs, as you see here. This ischemic compression might cause the classic radiation sign, which can go to the popliteal fossa, or if we always focus on the tense area, that is, the exact trigger point, sometimes we may also observe some borderline fasciculation. It is very important to remember that while we perform this technique, and since the piriformis passes like a bridge over the sciatic nerve, we should be cautious that the patient does not report any significant paresthesia, because at that stage, we could have made the sciatic nerve more sensitive. It is important to note that this last occurrence is quite rare, as in most cases, the patient will experience radiation solely from the treatment of trigger points and nothing else. So, in summary, this treatment consists of the location of the trigger point and applying direct pressure to inhibit it. The patient must be in a comfortable position to ensure the affected muscle is relaxed. We identify and locate the trigger point with flat palpation using our thumb. We apply pressure gradually, steadily, and slowly to the trigger point until we detect the first palpable barrier. We maintain the pressure until we feel a softening of the trigger point. The wait can be seconds or minutes. We repeat the action, increasing pressure on the trigger point until we find a subsequent barrier, and so forth. After maintaining ischemic compression for about 30 seconds, it will feel almost like a slow progressive settling of the muscle, which causes the hand to sink slowly downward. At that point, we release and then increase the pressure on the trigger point until we find a successive barrier, and we repeat until we feel a density that is almost normal under our fingers. At that moment, we move to another trigger point and repeat the same treatment.
That's it for this Trigger Points Masterclass. I hope it helped you gain clarity and confidence in your manual therapy practice. Now, if you want to keep learning, click on the video thumbnails on the screen to explore more techniques and tutorials on manual therapy. Don't forget to like this video, share it with your colleagues, subscribe to the channel, and leave a comment below. Your feedback keeps us going and helps us create even better content. And before you go, check the link in the description to discover our complete video courses and take your skills to the next level. Thanks for watching and see you